brief overview on ultra-conservative dentistry. We'll make sure we'll keep another YouTube live just for this so that we can cover the entire topic well. So let's just start off and explain. Let me explain what's ultra-conservative dentistry. So it's a subset of minimal intervention dentistry, which is aimed at conserving a greater part of the tooth. So we are trying to increase the patient comfort while decreasing the amount of dentistry that is done on the patient. So we are talking about minimal preparations. We're talking about adhesive dentistry, and we are also going to cover the usage of lasers and air abrasion and other techniques and materials which are helpful in minimal intervention dentistry. So fortunately, the current era of dentistry has brought about new materials, techniques, and instruments that can make conservative dentistry practical and ultra conservative dentistry a reality. Right, so this entire minimal intervention dentistry is a philosophy more than a particular treatment aspect. It is the mindset of the clinician who is working on the patient. It starts off with just the detection, the early detection, making sure that we are addressing the disease at its earliest stages, and we are being as minimally invasive. And this entire treatment is aimed at having a patient friendly approach, and to also help in reversing the any reversible damage would be reversed, and irreversible damage would have to be restored with whatever little is left. So GJ Mount was the first person who spoke about the need for minimal treatment, and also Davis and Mackinson were the first to coin the term minimal intervention dentistry. So the core principles revolve around recognizing the disease at its earliest possible stages, reduction of the caries risk factors, regeneration and reversal of any incipient lesions, and also repair of whatever has been removed from the tooth structure. So, ultra conservative dentistry is defined as a principle that is highly respectful of the tissues, seeks to minimize removal of healthy tooth structure, it is highly aesthetic, and uses strength of restorative materials to reinforce the remaining dentition. So this includes maximum preservation of the remaining dental structures, future therapeutic intervention under the same conditions, that is any repair or replacement, and the control of etiological factors and risk factors of the disease, and achieving high functional aesthetic outcomes. So the entire question of whether the cavity is clean of any decay or not has been addressed by various clinicians and researchers in the past, and is still being researched extensively. Masler and Fusayama were the first to show that only the infected dentine needs to be removed, and the affected dentine has to remain. So this is the basics of cariology. I expect everyone listening over here to know the difference between affected and infected dentine. So let's just look into the brief differences once again. Affected dentine has fewer bacteria than infected. Infected is highly invaded by bacteria. Infected is unmineralizable, so you cannot reverse it. However, affected dentine is remineralizable, so it's a reversible carious lesion. Also, affected dentine is vital tissue, whereas infected is necrosed. Affected is still sensitive because it has some nerve endings intact, whereas infected dentine is without any sensation. Affected dentine is useful for our remineralizing procedures, whereas infected dentine is not useful, so it has to be removed. So, a 2006 Cochrane review compared the consequences of complete caries removal. So, there was a 98% study reduction in the pulpal exposures for incomplete caries removal. What that means is that even if you removed caries incomplete, if it wasn't completely removed, there would still be a reduction in pulpal exposure, and still there wouldn't be a progression of decay, and longevity of the restoration would still be the same. Which means to say that stepwise or partial caries removal is considered preferable to complete caries removal in minimal intervention dentistry principles, and this is to reduce the risk of caries exposure of the pulp, and to make sure that whatever damages occurred can be reversed. So during the initial days of minimal intervention dentistry, these pits and fissures were removed using these small burrs in order to be more of a, it's more of a preventive protocol to prevent any pit and fissure caries. So prophylactic removal of pit and fissures and restoring them with amalgam and all that is not advocated anymore. Right now it's the era of adhesive dentistry. So a quick question to you guys. Now, what is the intercuspal distance in fissurotomy cavity preparation? If you guys know it, you can just put it in the live chat box. That will help us in knowing that you guys have understood the question. So over here, we're speaking about the distance between, that is the width of the cavity. So what would be the width in a fissurotomy cavity preparation? If you're preparing only the fissures, so in a standard amalgam preparation it would be somewhere around one third of the intercuspal distance, but in fissurotomy it is just one eighth, right? So it is an ultra conservative approach to the prophylactic odontomy, what we spoke about earlier. But instead of increasing or removing prophylactic, it would be in cases where there is early signs of caries. So over here, very minimal preparations are done using fissurotomy burrs, which would give us an effective width of the restoration to be only one eighth to one tenth of the intercuspal distance, as compared to conventional amalgam restorations, which is which requires some amount of a box, some big a sized box to accommodate the restoration for its retention and resistance form. So a box shaped cavity of one third the intercuspal distance is for amalgam, but for ultra conservative resin restorations, we are speaking only about one eighth to one tenth the intercuspal distance. So it is far less invasive than these carbide burrs. You get separate fissurotomy burrs by SS White and by other companies. So these are anatomically designed to enlarge only the fissure and eliminate the small caries without removing excessive healthy enamel or dentine. So another question over here. Can which of these following statements is true? Uh, a straight fissurotomy burr cuts rapidly and in an aggressive manner, or dentated burr cuts slow and provides a smooth finish. Great white burr is fast and provides a smooth finish, or all of the above. So I want you guys to kind of understand that this is a very current topic, considering that we are heading towards non-aerosol procedures during this COVID or these pandemics, right? So we are speaking about non-aerosol procedures as much as possible in order to reduce the viral load in the ambient air. So in such cases, we want something which can give us a finish that is as good as a burr, but at the same time have very less aerosols. So fissurotomy burr, because it cuts very less, the amount of water also required is less, and thus the aerosol produced is much lesser. So does anyone know the answer for this particular question? What is the what are these burrs, and which of these following statements is true? You can just drop it in the box. So over here, actually the great white burr, these are the three different burrs: the straight, dentated, and SS white great white burr. So these are the three different fissurotomy burrs that I used. The straight burr is smooth cutting, but it is slow and can have difficulties in cutting harder materials. So it's more like a finishing kind of a burr. So it's very smooth burr that is used only in cases of finishing off the fissurotomy preparations. It cannot be used on any restorations. It cannot be used on any sclerotic dentine, for example. In those cases, we need something which is faster and more aggressive. So dentated burr and SS white great white burr, these two are more aggressive. But dentated burr, again, it is not smooth in the sense that it is very aggressive and it gives a rough finish to the entire preparation. So we want something like the smooth aspects of a straight burr, but still the aggressive nature of the dentated burr. So both of them fused is the SS White Great White burr, which is faster, smoother cutting, and it does not grab or catch or stall into harder to cut materials. So this is a simple clinical photograph showing a fissurotomy preparation. You can see how minimally invasive the preparation is. Only that groove has been, or that fissure has been prepared with using the fissurotomy burr, and it has the cavity has been etched, and then an adhesive restoration is placed. You can also see that this preparation, this kind of a preparation is generally deep, meaning that it extends beyond the DEJ, but at the same time it is very narrow. So we need something like a high flowable resin restoration. The conventional amalgam cannot be used in these areas because the retentive form is not in place. We want something which bonds to the tooth, and it also has to have a high amount of viscosity. Sorry, a low amount of viscosity. It should be high flow material. So something like a low viscous but a high filler load flowable resin restoration can be used for post fissurotomy restorations. So you can just see how thin and tapered the preparation is without any retentive locks. So resin restoration would work best in this kind of a scenario. So the next question is the removal of a shallow developmental fissure or pit in enamel to create a self-cleansing smooth saucer-shaped surface is known as. So is it called as prophylactic odontomy, fissurotomy, enameloplasty, or none of the above? So we already discussed prophylactic odontomy. It is just removal of the pits and fissures. Prophylactic itself, it's a preventive approach. You fill it up with amalgam, but you need to really widen those grooves and pits in order to accommodate your restorative material. But in cases of fissurotomy, we spoke about using specific thin tapered burrs, fissurotomy burrs like the straight dentated and the great white burr. These are useful in making sure that our preparations are pretty tapered and narrow, but at the same time accommodates a restorative material. So that is fissurotomy. But when we remove a developmental fissure or pit to create something which is self-cleansing, or to create something which is free of any catchment areas, is known as enameloplasty. So in that, what we do is we just take a small round diamond or a carbide burr, and we just run it over this shallow developmental fissure or pit to create something which is more smooth and self-cleansing, so the patient can easily maintain the hygiene in those areas. So this is a brief overview on the different kinds of preparations. These limit to the drills. Then whatever we speak next in minimal intervention dentistry or ultra conservative dentistry revolves around air, light, and it also has a lot of sand involved. So we are speaking about air abrasion. We'll be discussing about lasers. We'll also discuss a small portion on micro conservative tunnel approaches for aproximal lesions. So those proximal caries lesions which require no removal of the marginal ridge can be done by approaching that through a tunnel kind of an internal cavity preparation. So we'll be discussing all these in the forthcoming session, forthcoming live session on ultra conservative dentistry. We'll also discuss uh, the ninja axis cavity preparation or the ultra conservative axis cavity preparation and modern endodontic axis cavity preparations, which is the ultra conservative endodontics part. We'll be dealing with that as well. We can also discuss a little bit on callalily enamel preparations for endodontic axis cavities. So there's a lot of ultra conservative means of approaching our day-to-day dental diseases that we see, and that will help in us getting a better overview. All right. So I think we can wrap up this session today. It's been a small, brief session of just a few minutes, but I think it throws a lot of light on being more conservative in our dental treatments. So we have discussed in a prophylactic odontomy, enameloplasty, and fissurotomy. We'll quickly speak about lasers, air abrasion in the forthcoming sessions. So thank you all for watching today. Sorry for the technical difficulty in the start, and we'll get back